Good morning, Professor Karim. It is such a privilege for me to welcome you to the Public Economics Winter School. I don't think I need to introduce Professor Salim Abdul Karim. I felt like you were a beloved family member that helped navigate the absolute confusion of last year and this year, indeed, for me. Professor Karim, I just think we're waiting for a few more people to join. Okay, tech team, are we good to go? Yeah, I think we are. Okay. So I was saying, Professor Karim, that you were like a beloved family member helping us to navigate the confusion and the fear of the COVID-19 pandemic. But that's not what you are all about. If we read your bio, we see an incredible career in medicine. And indeed, clinical infectious diseases is your space. You're an I'm not good with these words, epidemiologist, and you are recognized globally for your contribution to HIV prevention and treatment. You have developed a number of patents. You are a professor at the Mailman School of Public Health at Columbia University, a director of the Center for AIDS program in South Africa, CAPRISA, the Vice Chancellor for Research at the University of KZN, and adjunct professor of medicine at Weill Medical College at Cornell University. And you co-chair and chair a number of expert panels. So let me not take any of your time. We are thrilled to have you here. Thank you so much. You're going to be giving our keynote address, which is on South Africa's health response. What have we learned over the past 18 months? Over to you, sir. Thank you, Prof.
It's a great pleasure. Thank you very much for having me on your program in this winter school. I'm going to share with you my slides. Okay, and I think I've got it right. If you can just confirm that you can see my slides occupying the full screen.
You've got it so right. It's looking beautiful. Thank you.
Okay, we're all set to go. Well, thank you very much. It's a great pleasure to be with you here this morning. What I want to do in the next 20 minutes is I want to tell you about South Africa's COVID-19 response, and I'll be focusing on the health aspects predominantly. And I'll touch on some of the key lessons we've learned in the past 18 months. And I hope through that, I will share with you the good, the bad, and the complicated. And I have to start with a disclosure that I stole this from a movie, of course, that many of you may be familiar with. It was an old Western movie, The Good, the Bad, and the Ugly. So I'm going to talk about, to start with, the good, some of the scientific innovations, vaccines, and the way in which we responded. I'll talk about some of the bad. I'm going to talk about new variants, corruption, and I'm going to talk about vaccine nationalism. And then I'm going to deal with some of the more complicated issues, making difficult decisions, dealing with conspiracy theories. And I'll end off with, what is the kind of visionary future we need to deal with this pandemic and with the future pandemics. So let's plunge directly into it. So I'm going to start with just giving you a quick overview as to where the epidemic is as we speak. So we have from our first case on the 5th of March last year, we started with a rapidly growing epidemic. Because of our very early action, we slowed the spread of the virus at that point. And in slowing the spread of the virus, we flattened the curve, giving us time to prepare. And then we went into our first wave. Now, when we look at the first wave with hindsight, it was quite a mild first wave, especially when you look at the number of admissions and the number of cases and deaths. We then had a lull of around 99 days. and we went into our second wave. And our second wave was much worse. It was driven by a new variant, which we knew at the time as the 501YV2, and today is called the beta variant. And then we recovered from that, somewhat battered, somewhat bruised, but we recovered. And we went into another lull for about 99 days again, until we hit our third wave. And our third wave, driven by yet a new variant, the Delta variant, has been even worse than what we've seen with the first and second waves. In fact, we are still in the midst of this third wave, as we all know. And if we look at what that third wave looks like in the different provinces, just to give you a quick overview, Gauteng had it bad. Where you are, you've had it really, really difficult. When you compare the first and second waves in Gauteng, which maxed out at around 35 cases per 100,000 population, and you compare that to the third wave, which was more than double what you had in the first and second waves. This third wave was a monster when you compare it to what you saw in the first and second waves. And on top of all of that, you were trying to fight this wave with one hand tied behind your back, in that your main weapon against the deaths and the hospitalizations is the Johannesburg General Hospital, the Charlotte Maxeke Hospital. And that hospital, as you know, had a fire and was out of commission. And so this was really a challenge to deal with this pandemic in Gauteng. And you can see the hospitalizations from the first wave through to the second wave, and look at the third wave, just the mountains of hospitalization. I mean, I can only imagine how tired doctors and nurses are in the hospitals in Gauteng, having dealt with this wave. If we look at, what about the rest of the country? Well, the Western Cape had a sort of meandering third wave. When you compare its first wave, which was relatively mild, to its second wave, which was really terrible, the third wave has been somewhat in between, climbing slowly, and so it put less pressure on the healthcare system. And now it's hit its peak and it's on its way down. Whereas if you take KwaZulu-Natal, partially driven by the unrest and the looting that we have seen, the gatherings as a result, we had a dip in testing because the labs were all closed. But now that it's come back, the epidemic is now on the rise. And it's left to be seen where this heads to, but it's quite likely to head up to somewhere between the first and second waves. So all of this is giving us an unusual picture, because you've had one province that's finished its third wave. You've got one province that is still, hovering at the peak and just on its way down, and you've got one still climbing to its peak. And so that's why when you see this downward curve, you can see it's meandering at this point and not going straight down because of the differences between the provinces. So while we are dealing with this pandemic in South Africa, we sometimes lose sight that actually the whole world's dealing with this problem. I mean, we are so insulated, and sometimes we are so inwardly looking, we forget that this is a big crisis, and there are countries across the globe that are dealing with this nasty virus, and that the Delta variant is causing havoc across the world. And when we sit back and just look at the sobering numbers of 207 million cases and 4.3 million deaths, we get to understand that we're just a drop in this major ocean. I mean, it's an important drop to us because we live here, but we have to understand that we are dealing with a pandemic. It's affecting every part of this world. No part of this world has been exempt from this virus. So let's get into what have we learned. Right? We've been dealing with this now for about 18 months. What have we learned? Well, let's get on to one of the good things that happened. Well, it was quite fascinating to see how we worked at the early part of this epidemic in April last year in the Ministerial Advisory Committee. We saw straight away the importance of oxygen supply. Without oxygen and a secure supply of oxygen, people were going to die. So we had to do that. And so we made some recommendations, and government went into gear. And with the help of an NGO called Right to Care and Deloitte and all our players came together. How do we secure oxygen for every hospital? Well, we looked at and modeled what our needs were going to be in the first wave, and we were short. We were desperately short. How are we going to deal with that? Well, we thought the best way is, why don't we bring the oxygen manufacturers around the table? Let's have a discussion with them and let's work with them in fixing this problem. Well, it turns out you can't do that because of competition rules. And so we had to get an exemption from the Competition Commission, and we were able to bring them around the table. And as they sat there and they looked at us and looked at what their maximum capacity was, we still realized, even at maximum, with all of these 4 big companies, we would still be short of oxygen. So we had to look at an alternative. What was the alternative? Well, they tell us about half of the oxygen they manufacture goes to commercial processes. And so they agreed that during the peaks of the wave, they would no longer supply oxygen for commercial purposes. They would inform their clients and they would redirect all oxygen to medical purposes. But if they were going to do that, we had to have the storage capacity. So we started building the storage facility. And we had to ensure that every hospital had a storage tank for oxygen on site and at least 30 minutes away to be able to get oxygen if it starts running low. Well, it was a major effort to do all of this. And in doing all of this, we ensured that during the first and second waves, and certainly now in the third wave, no hospital, public or private, has run out of liquid oxygen. We have had some challenges with cylinder oxygen because of the large volumes of oxygen you need. A single patient uses more than 1 full cylinder a day. So you can imagine the challenges if you don't have piped oxygen, as we don't in some of our very small hospitals. We had a challenge in ensuring that we could supply cylinders fast enough. But even there, we've ensured now that supply chain for cylinder oxygen is enhanced. So saving lives, critically important. Make sure you have oxygen. And that's what we spent a lot of time doing. And it's all done behind the scenes, but you can see how critically important it was. But it wasn't only that we supplied oxygen. What about the machines to deliver the oxygen? Well, one of the very early things done in March last year, was the government and DTI brought together under one umbrella a group of people to make ventilators. And one of the big companies, DeFi, the one that makes your microwave ovens normally and your stoves and fridges, DeFi changed its entire line to making ventilators. So when you go into hospital right now, you will very likely, if you've got COVID and you need oxygen, the actual machine that's providing the oxygen to you is probably made by DeFi. A company never made oxygen machines before. And this is the first in Africa. So we manufacture now our own ventilators and our own systems to provide oxygen through nasal cannula and mask. So just giving you a sense of oxygen supply. But let's talk about something else that was good. Let's talk about some of the scientific innovations. I mean, in diagnostics, we had a diagnostic for this virus within 3 weeks of the first cases being reported. We had the viral sequence, the genome sequence, 11 days after the first case was reported. It is on a scale I've never believed possible. We had a vaccine within 9 months of the first case being reported. I mean, I've been working on HIV vaccines for 32 years, and we still don't have one. So it just gives you some idea of the speed with which we were able to work, we meaning the scientific community, to do this. and to repurpose existing drugs like dexamethasone, tocilizumab, to give us, just some impression about how we can make a difference in using science to enhance our response. And even if you take vaccines, even though we had a delayed start, vaccination coverage now is increasing quite rapidly across the country. We have at this point given at least one dose to about 1/3 of the eligible population, and close to 1 out of 5 South Africans in the eligible age group above age 35 has been fully vaccinated. So we really are getting now this on steam. It requires all of us to pull together to make it all happen. And in all of this, we've been very fortunate, I think, to have had open communication. I've dealt with several epidemics in my life, starting with the first epidemic I studied back in 1980s on measles in northern KwaZulu-Natal. I chaired our country's polio expert committee that oversaw the elimination of polio in South Africa. I've been involved in TB, HIV, it goes on. I have never seen this level of public engagement. I've never seen this amount of information being shared. Everybody in our country knows every day how many cases, how many tests, how many deaths, how many people vaccinated. It's never been done before. And you now have a minister every Friday gives you a weekly update. You have the president calling family meetings to discuss this virus. And you can see it's just a different level of communication. Now, there'll be those who say, oh, it's not enough. We want even more communication. Well, we can always do better. But you have to look at how much this has changed how we respond to pandemics and epidemics. So I've touched on the good. Let's touch on the bad. Well, when we saw the first cases, and I was on vacation in the Drakensberg Mountains, and my iWatch sent me an alert. It's a ProMed alert that all of us around the world who are part of the Infectious Diseases Society, we get this alert. And it was the first notification to the entire world outside of China that there is a group of cases of an unknown etiology in a small hospital in Wuhan, China, of pneumonia. And I looked at it and I just disregarded it. I said, why are they telling us about this pneumonia? I didn't regard it as important. Well, 11 days later, when the sequence was published on Twitter, imagine that, a sequence of a virus on Twitter. You'd think it would be in the journal Science or Nature or something. No, it came on Twitter. And my colleague came up and showed me, I don't do Twitter. And he says, here's the sequence. We looked at it, we realized we're dealing with a problem. And within a matter of 2 weeks, or 2.5 weeks thereafter, it's declared a public health emergency of international concern. And what we saw is a virus that quickly came to dominate the world. And what happened was that barely 9 months later, on the 9th of November, we heard about this amazing discovery. Yes, we have a vaccine. The vaccine is safe. It's highly effective. At that time, 95% effective. Wow. We don't have vaccines that good except for measles, perhaps. So it's really, really amazing to see that. But our joy was short-lived. Barely a month later, on the 14th of December, the UK announced its new variant called the Alpha variant. We announced 4 days later the Beta variant. And shortly thereafter, Brazil announced the Gamma variant. And then a few months later, India announced the Delta variant. Variants have changed the game because we now have a virus that's rapidly mutating. It's a virus that's changing itself. It's adapting. And that means that over time, there's a likelihood that our vaccines will no longer be effective. We're going to need to play this game. We create a vaccine with immunity against the virus. The virus will mutate, trying to escape our immunity. We make a new vaccine. And so we're going to have to deal with this virus and its wily attempts to evade our immunity. And what is this? What are these variants doing? Well, look at India, Brazil, and South Africa. each of us had our first wave. India had a very minor first wave. In fact, the politicians declared they had conquered this virus. Brazil, nasty first wave. Nasty. And if you look at South Africa, ours was quite a severe first wave, but not something we couldn't deal with. But all that changed. In India, they had a Delta variant outbreak, and you can just remember all those pictures we saw on our TV screens of the mayhem, the disaster that was created in India due to the Delta variant. Patients dying, waiting outside the hospital, no oxygen available, just all of the challenges that the Delta variant created. In Brazil, the Gamma variant led to their third wave and is still driving their third wave. If you look at South Africa, we had the Beta variant drive our second wave, and now the Delta variant driving our third wave. So variants have changed the game. They have created in our setting repeated waves because they are spreading faster and in some instances can even bypass some of our immunity. But in all of that we've seen with these variants, with the vaccines, one of the things that has been really shocking has been the level of vaccine nationalism. That countries like Canada and Australia and Britain on the right-hand side, you can see here, Canada bought 10 doses of vaccines for each one of its citizens. I mean, just think about it. They have overbought so much of vaccines, and that means that there's less vaccines available for the rest of us to buy. And so it's richer countries that through their advanced market commitments, just using their financial clout, were able to secure the lion's share of vaccine, far more than they need. Whereas Africa simply had to depend on COVAX. We had to depend on the mechanism created by the World Health Organization, Gavi, and CEPI, a mechanism to secure vaccines from various manufacturers and provide it either free or at a highly subsidized price to the countries in Africa. And so you have the situation now, barely 3-4% of Africans have been vaccinated compared to around 20% of the rest of the world. We've also seen another bad. We've seen how in our initial level 5 lockdown, when South Africa deployed 70,000 troops to enforce the lockdown, whereas they only deployed 2,500 when there was looting, you can see that we've had to deal with those challenges and that the troops were not really in a position to do this. They don't have the kinds of authority to arrest people and so on. And we had a very unfortunate case of Collins Khoza killing and the violation of human rights that we have seen with our troops. But for me, one of the most disappointing has been to see the misuse of funds, the corruption that we have seen so pervasive in our provinces. But I thought I would include this article from The Guardian that even in other countries, in this case, the UK, about 1/5 of UK COVID contracts were raised flags for possible corruption. So this is a problem that we don't fight on our own. Doesn't mean to say, it's okay that it's being done elsewhere, but it just tells us it's a global problem and we've got to do better in fighting it. So I've talked about the good, I've talked about the bad, let's go to complicated. Well, let's start with probably one of the most complicated things that we had to do, and that is we had to make difficult decisions. We had to bravely face the problem. It's an unknown entity. It's March 2020. We know so little about this virus, and yet we're having to make quite drastic decisions. We're having to curtail constitutionally guaranteed rights and freedoms, and we have to do so quickly. And so we had a situation where the president instituted the lockdown on the 23rd of March last year. And when you compare that, when we looked at the HIV situation, where we responded to a pandemic with denial to start with, in this case, we were dealing with, yes, we got a problem, we got to be decisive, we got to take brave decisions, might not be the best decisions, but we got to make the decision, we got to get on with it, because dillying and dallying will just make things worse. In the US, they had the opposite problem, right? They had what we had in the HIV situation, with a president that routinely denied that this was even going to be a problem. Oh, it's going to disappear in the summer, It's not going to be a problem. Unfortunately, they've changed now to a president that takes it seriously and acts decisively. And we've seen how Neil Ferguson, one of the epidemiologists advising the UK government, how he showed with his analysis that the UK that delayed its pandemic response, delayed its lockdown, he showed how just bringing the lockdown 1 week earlier would have halved the number of lockdown deaths in April. So just showing you how 1 week makes a difference. There's really no time here. Time is not on your side. You've got to make difficult decisions. The level of information you have is imperfect. You just got to make decisions on the best available information. That's what leadership is required to do in a situation like this. And we've had to deal with conspiracy theories, miracle cures. In the first and second waves, the first wave, I had to deal with this hydroxychloroquine. The number of times that people have attacked me for hydroxychloroquine. And eventually now, of course, we know hydroxychloroquine doesn't work. In the second wave, and now in the third wave, I had to deal with ivermectin. People want a miracle cure. They're watching their friends getting sick, dying. They want a miracle cure. Why are you not allowing them this miracle cure? Now we're dealing with vaccines, and we've got people who are deliberately sowing division with misinformation, actually blatant lies, as we've seen most recently with one of the cardiac surgeons in our country. So we not only have to deal with a difficult disease, we not only have to deal with one that's spreading rampantly, putting pressure on our healthcare system, and people are dying by their thousands. We're having to deal with all of the conspiracy theories, the people who, instead of dealing with the problem, want to bicker and want to create all kinds of, new dimensions to the problem. And they will always differ. No one can get anything right. Only they know what the answers are. So we have to deal with that. So let me go on to the last point I want to make in the complicated, because I thought you might want to know, so what's going to happen next? Well, nobody knows what's going to happen next. Let's give one possible scenario. Well, if we look at our first wave, which lasted 74 days, and our second wave that lasted 75 days, and if we look at our current wave, which we anticipate will be around 100 days, just because of the differences between the provinces, then we know that we can expect another wave, a fourth wave, roughly of around 75 days or so. And if we look at the interwave period, it was 94 days between the first and second, 99 days between the second and third. So we can expect to have an interwave period of around 99 days, plus minus. So if you had to ask me, hello?
Hello? We can still hear you, Prof. Carry on.
So if you're asking me, this is what we're looking at in terms of, what does the future hold in store? So let me end off with, 5 key lessons that we can take away from this. That we took the disease seriously, acted timeously. We maintained proactive communication. We have seen that the importance of dealing with this with ethics, with morality, because we've made so many errors. We've had so many problems. We've had so many abuses. We can move mountains when we act together. We saw that in the way DeFi made ventilators, the way the Cape Town ICC was converted into a field hospital within a matter of 6 weeks, with 800 beds fully supplied with oxygen. And we need to draw on this experience to prepare for the next pandemic. And as I look at, what can we take forward? What message can I leave you with? In a career of 32 years dealing with the HIV pandemic, I thought I would share with you a key lesson from HIV for COVID-19. And that is the importance of understanding and acting on our mutual interdependence. And I like to quote here from UNAIDS. The AIDS movement demonstrates that with a shared vision, shared responsibility, and through global solidarity and leadership of people living with HIV, affected communities and individual actions, we can change the course of history. And so we have. HIV that was a death sentence is now a chronic treatable condition because of global solidarity, the Global Fund, UNITAID, PEPFAR, and we created COVAX in that mode. So let me end by just quoting from Pope Francis. The pandemic has exposed the paradox that while we are more connected, we are also more divided. To come out of this crisis better, we have to recover the knowledge that as a people, we have a shared destination. The pandemic has reminded us that no one is saved alone. What ties us to one another is what we commonly call solidarity. Solidarity is more than acts of generosity, important as they are. It is the call to embrace the reality that we are bound by the bonds of reciprocity. I am safe when you are safe. You are safe when I am safe. No country is safe until we are all safe. Thank you.
Wow, thank you so much, Professor Karim. You can see the emojis are raining up. I don't know if that's English, but they are a great appreciation for your keynote address. I can't think of a better way to get this winter school going. I loved the points you raised at the end, Prof. You know, I am safe when you are safe. Perhaps that sort of encapsulates it all. And it's not just safety from the pandemic, but it's generally safety in all aspects, the systemic connections, which will determine our human future. Poverty, all these challenges which the public sector and indeed the whole of South African society and perhaps global society is faced with are interlinked, and the pandemic has given us a jump start into that reality. Prof, we've got a few questions in the Q&A. I'm going to just read them out and ask you to respond to them all in the way in which you see fit. I'm tempted to abuse my position as the facilitator and just completely disregard time, but I will not survive that if I do. So I'm going to just read them out and ask you to give a consolidated response to those as your final input to us. So if there's one question coming from Zain Mayet, who's asking about whether we shouldn't open up the vaccination to the younger age groups. Given that we're currently at 175,000 a day, we should be at 300,000. So your thoughts on that. Then linking to some of your latest slides, why are some health workers avoiding getting vaccinated? And particularly a reference to a GP who is not wanting to get vaccinated. That makes all of us nervous. Are we equipped to develop our own vaccine in terms of our R&D capabilities? And let me, the questions are just flooding in now. Isn't that fantastic? And isn't it tricky that we can't get you to answer them all? But perhaps you can, Prof, depending on your availability, have a look at some of these questions and perhaps type some responses. But there's another question on how we should judge decisions made during the pandemic. Is it fair to use hindsight on this? I mean, I think that your point around, leaders need to make decisions with the best information they have. It's such a lonely place to be because that's all you can do is make decisions with that. Okay, can we get your slides? I'm sure the Gtac team will be able to respond to that. Yeah, and then vaccine hesitancy and herd immunity. Let me stop there, Prof. There's so much interest in what you've presented, but let's go with those ones, and that's where we'll end your input. Thank you very much. Over to you, Prof.
Sure, thanks. Okay, so let me deal with some of the quick ones. So we cannot vaccinate individuals below the age of 18 because the vaccines have not been tested in young people yet. There is two vaccines, the two mRNA vaccines that have been tested in 12 to 18, And so we could go down to 12 if we use those vaccines. But as far as going down to age 18, that is the plan, and it will be in all of 13 days from now that we will be opening up and vaccinating the younger ones. It's quite important to prioritize, because the maximum benefit, especially when we have low quantities of vaccines available, the maximum benefit is for older people. So the benefit gets much less as you start vaccinating younger and younger people. So it's important to do this prioritization. And you are right, we should be opening it up now to pretty much to anybody, actually, above the age of 18. And it should really be on the basis that we do have adequate quantities of vaccines now, because of the secure supply that we have from Pfizer. So I think it's all good. I agree with you. We should open up. Should we have opened up already? It's a 50-50. We don't want to really compromise the elderly coming forward. We want to still try, and we've only covered a third of them, so we've got to still catch the other 2/3. And that takes me to the next question you asked, which is, what about the challenge of making difficult decisions and creating a lonely place? Well, I told the president very early on, I said, no matter what decision you make, you are going to be attacked for it. You cannot win. There is no winning in this. You just have to make the decisions as best you can, because if you make a decision in this direction, you will get that group attacking you. If you make it in that direction, the other group is going to attack you. That's life. I said, this is not a popularity contest. This is about using the best science we have and making the best decisions you can, and you will make them wrong. They won't all be perfect. Make no mistake about that. So that you don't make a decision is the greater hazard. Make the decision. And so we actually have been very fortunate. Our president has been willing to make those decisions, difficult as they are. If you take, have there been a lot of wrong decisions? No. And how do I know that? Well, there are over 100 court cases that the public and various organizations have challenged the government on, whether it's the government's decision to close the beaches or to institute the lockdown and so on. Every one of those cases, government has had to deal with. Now, I have given evidence on, more than 24 of these cases. The government has never lost a case where I've given evidence so far. So every one of those cases, the government has won. The government's lost 2 cases so far. The first was on cigarette smoking, and that's now on appeal. The government did lose something else, by the way. It lost the case on the level 3 regulations, which was overturned by the Supreme Court of Appeal. So ignore that one. But the only other case the government lost was one part of one case, which was relating to its regulations on hot food. And that was overturned by the Western Cape Court. So in all of 18 months, 2 things were found to be, by the courts, were not supported. The first was the hot food, which the government didn't challenge. Smoking decision. There were 2 smoking, one in favor of the government, one against the government, but that's under appeal right now. So let's wait to see what comes of that. The issue relating to vaccine hesitancy, not wanting to be vaccinated, I think we have to accept that in life, people, when they're anxious and when the world doesn't make sense to them, and what they understand as their comfort zone has now been removed, and they can't deal with the situation, they need to blame somebody. It's how you make sense of the world. Because if you can't blame somebody, you've got to blame yourself then, or you got to find somebody to blame. And so you blame people in power generally. So take Mr. Gates. He's the most powerful person. He's got the most money. He's putting chips in our vaccine so he can monitor where we are. I said, yes. Mr. Gates got nothing better to do with his time but to put chips in our vaccines so that he can monitor what our movements are. I said, if that's what you think vaccines are about, it's just crazy. But people just, choose to believe crazy things sometimes because that's what helps them make sense of their world. It's very hard to challenge that. I have, in all my time, when people raise these things with me, these crazy conspiracy theories, I simply say to them, you have to believe based on what you think is the best evidence. I'm sharing with you the best scientific evidence. I'm not trying to convince you. You don't have to believe what I got to say. But here's the evidence. You can reject the evidence, but that's the evidence. And so that's what when you see what my task is. My task is to enable you to make a decision. My task is to provide you with the best available science to do that.
Well, Prof. Salim Abdul Karim, you have certainly inspired us. We might want a miracle cure, but in the absence of that, you definitely are the next best thing. Thank you so much for your words of wisdom, for your inspiration, for your commitment to our humanity and our country. You make us so proud, and I think you've inspired all of us, young, middle-aged, and old, to continue in the path of public service. People want you to stay on. I'm so sorry, Prof, that we can't carry on talking. Perhaps if you have some time, you can scan the chat, the Q&A. But we know you're an incredibly busy man. But please accept our heartfelt thanks for joining us and inspiring us at the beginning of our winter school. Thank you very much, Prof.
Thank you. It's a pleasure. Bye.
Bye-bye. We are now going to move to our next slot, which is responses to the pandemic in different parts of the globe. So we're going to join that segment. You will know that we are running a little bit late, but I think it was worth stealing some of that time. We'll catch up some of the time, and we might run a few minutes late for the program of the day itself. But when you've got such inspiring inputs, it's worth investing the time. So let's go to our next segment. I will introduce our speakers there. While you walk to the next segment, I would encourage you just to get out of your chair, take a stretch so that we don't end up creating injuries by sitting too long. But I'm not going to pause the program. Let's just, as we go out of the segment, stand up and then sit down, and I'll introduce our next set of speakers. Thanks, tech team. We'll go to the next segment. Technical team, if I'm still live, there we go. Okay. Can we move to the next segment, please?